Hi, my name is Connie Kaplanis and you're watching the video on the introduction to the classification of esodeviations. Okay, here we have a flow chart of how we classify a patient with an esodeviation. This is not an exhaustive list. There are other esodeviations that are not mentioned specifically in this flow chart, but it does provide you with a good overview of what we'll be discussing in this inquiry related to esodeviations. Now, this may feel a little bit daunting because there are a number of deviations that we can see here, but we'll take it step by step, which will help you understand this complex flowchart. Let's start off with the first subclassification of an esodeviation. A patient with an esodeviation will either have an esophoria or they'll have an esotropia, so a manifest deviation or a latent deviation. Commencing with the esophoria, as with the exophorias we've discussed, the patient will either have a compensated esophoria, so one with rapid recovery or good recovery, or a patient might have a decompensating esophoria, in which case they're losing control of that esodeviation or the esophoria, and generally they'll present with symptoms because of the decompensation of the latent deviation. Now, just as with exophorias, we can subclassify a esophoria dependent on whether near distance disparity exists. The terms, however, are slightly different when we discuss esodeviations. And we have three types of classification in relation to this. We have a convergence excess esophoria, a divergence weakness esophoria, or a basic esophoria. In terms of defining these types of deviation, the convergence excess esodeviation or the near esodeviation is where the near deviation is greater than far. Divergence weakness or the distance esodeviation is where the far deviation is greater than the near deviation. And then again we have the basic or the non-specific where the near is similar to far. And as always, we need a difference of at least 10 prism diopters to begin classifying somebody as having either a convergence excess or a divergence weakness esodeviation. Let's now move on to the manifest deviation, so the esotropic patients. We have two types of esotropia. We can classify a patient as having either a nonaccommodative esotropia or an accommodative esotropia. Let's start off with the accommodative esotropia. An accommodative esotropia is one which is related to accommodation. Generally, in most instances, what we're talking about here is either the esotropia is related to a patient's refractive error, and specifically hypermetropia, or it's related to a high ACA ratio. So with every diopter of accommodation, the patient is doing an excessive amount of accommodative convergence. That's the majority of the patients. We also have hypoaccommodation as an issue, which I'll come to in a moment. Now, with an accommodative ET, you can either have an intermittent deviation or a constant deviation. With the intermittent deviation, you can have a convergence excess deviation, which is also known as a near deviation or a non-refractive deviation, or a fully accommodative deviation, which is also called a refractive deviation. Okay, what do these terms mean? A fully accommodative esotropia, or one that is refractive, is fully related to, is absolutely totally related to refractive error. What this means is that, as an example, if we have an individual who has hypermetropia of +3, without the glasses, they need to do an additional 3 diopters of accommodation, which brings on the esotropia. Which means when you correct that refractive error and give that patient glasses, they will be fully corrected, or their esotropia will be fully corrected, and the eyes will be completely straight. So the fully accommodative esotropia is where a patient's esotropia is totally related to the refractive error. And the reason they're intermittent is because the deviation or the manifest deviation is there without glasses but not there with glasses. And in some instances, even without glasses, the patient may flip between states of being esotropic and having an esophoria, so controlling it and not controlling it. Moving on to convergence excess, just as that term indicates, the deviation is greater at near. And it's intermittent because it's manifest at near, or we have a manifest ET at near, and generally the patient is straight in the distance. And there's two reasons for this type of deviation to occur. One is a high ACA ratio, and the other is hypoaccommodation. A patient with hypoaccommodative convergence excess has a near point of accommodation that is remote. And because of this, what happens is that there is an increased accommodative effort that's required in order for the patient to see clearly. And with this increased effort of accommodation, what happens is we get more accommodative convergence, or excessive amounts of accommodative convergence, because the patient is hypoaccommodating. And this then results in an esotropia at near. And the reason that it's at near and not at far is because it is at near that we require greater levels of accommodation. So it's at this distance that the manifest deviation will present. And just as I mentioned a moment ago, the intermittent convergence excess esotropia is also known as a non-refractive esotropia. And the reason is that the convergence excess pattern that we see is not related to hypermetropia. It's not related to refraction. What we have here is a high ACA ratio, or a patient who has hypoaccommodation issues, which results in the esotropia, and it results in an esotropia that's greatest at near, and where there is no deviation or manifest deviation in the distance. Whereas with fully accommodative, we obviously have hypermetropia, which is the issue resulting in the esotropia. These patients, although not documented here, generally have a basic type of deviation, similar near and far in terms of size. Next, we have the accommodative constant deviation, which is known as the partially accommodative patient, or a patient who has a partially accommodative esotropia. This is very similar to the fully accommodative in that it's refractive in nature. It is related to a patient having hypermetropia. The difference, however, between the partially accommodative and the fully accommodative is that when you give the patient's hypermetropic correction, or when you prescribe it to the patient, it will only correct part of the deviation. So let's say, for instance, we have a 30 diopter esotropia and we prescribe the patient's glasses. What we see once they return with their glasses on is that the deviation is not completely corrected. They'll go, say, for instance, from 30 diopters to 15 diopters, but it persists to be manifest and it's there all the time. So without the glasses, it's an esotropia both near and far and all the time. With the glasses, it's an esotropia near and far, but it's smaller in size. It's been partially corrected with a refractive correction. Okay, let's now move on to non-accommodative esotropias. A non-accommodative esotropia means that you will find that the correction of refractive error, so correcting any hypermetropia, does not change the deviation. That means that the deviation is not related to hypermetropia. It also means that if you find a convergence excess pattern, then you won't be able to explain that convergence excess pattern with a high ACA ratio. If a patient has a high ACA ratio and a convergence excess pattern, they're classified as having an accommodative esotropia. If a high ACA ratio is absent, then this patient is classified as non-accommodative. Let's look at this a little bit more in detail. Let's start off with the non-accommodative intermittent deviations. So as usual, you can classify a patient as having a convergence excess, a divergence weakness, or a basic type of intermittent non-accommodative esotropia. In terms of being intermittent, this means that the patient has control at some point in time. So for convergence excess, for example, it's likely that there's control in the distance. For divergence weakness, it's likely that there's control at near. And for basic, it's likely that it's controlled at various point in times at near and far. The difference between these intermittent deviations and those that we just discussed in accommodative ET is that, again, they're not related to hypermetropia and they're not related to a high ACA ratio. I have one other condition here that I've indicated, which is the cyclic esotropia, or the intermittent cyclic esotropia. A cyclic deviation is one that occurs intermittently at a regular interval. What this means is that we generally have an esotropia on alternate days on a particular cycle. So what will happen is, as an example, on Monday for 24 hours is an esotropia, and on Tuesday, for the same sort of period, another 24 hours, the patient is straight. And then on Wednesday, they have an esotropia. So it's cyclic in nature. Now, often, the frequency of the manifest phase of these patients' deviation will increase. And at some point in time, these patients will often become a constant deviation, in which case they will become a non-accommodative constant esotropia that was once an intermittent cyclic esotropia. And lastly, let's discuss the non-accommodative constant deviation. Here we can subclassify the patient as having a primary, secondary, consecutive or residual deviation. So, as with exodeviations, a residual deviation is where we have an esodeviation and post-operatively there continues to be an esodeviation. There's a residual esotropia. Consecutive, the patient had an XT originally and then post-operatively the patient now has an esodeviation. Secondary, a secondary esodeviation is where we have a patient who has lost visual acuity, has pathology of one eye, and that eye has now become esotropic. And lastly, we have our primary deviations. The causes of these are generally unknown, but they can be, for instance, anatomical or hereditary, etc. It's also worth noting that these accommodative esotropias, all of them, are considered primary deviations. I just haven't noted that in this particular flowchart. These deviations have etiologies that we don't generally see in the primary constant non-accommodative ESOs. We have refractive error that relates to why the deviation exists. We have ACA ratios and we have hypoaccommodation as some of the causes. Now, with a partially accommodative ET, refractive error is only part of the cause for the esotropia. There may be other factors that, such as anatomical factors or hereditary factors as an example, that relate back to why this patient has an esodeviation. In fact, fully accommodative esotropias are not only refractive in nature, but can be hereditary as well. Coming back now to our primary constant deviations, again, we can classify the patient according to whether there is near distance disparity, so as a convergence excess, divergence weakness, or basic. But we also have specific types of esodeviations that are classified as non-accommodative constant primary deviations. We have here the infantile esotropia. This is an esotropia that develops under 6 months of age. The acquired esotropia, which is an esotropia that develops after 6 months of age. We have the nystagmus blocking syndrome. What we have with the nystagmus blocking syndrome is a patient with manifest nystagmus, and this manifest nystagmus is generally blocked either totally or partially by the eye being esotropic, and specifically by an eye being in an adducted position, which is what occurs with esotropia. Okay, another condition we have is an esotropia with myopia. Now, when we say an esotropia with myopia, we're actually talking about patients with a high degree of myopia over 6 diopters. And in this instance, what's happening is we have a patient who has a far point that's very near, and what the patient is doing is that they're trying to utilise that far point to see clearly, and then not relaxing their eyes or their convergence in the distance, which means they'll be esotropic in the distance, and eventually they develop a constant esotropia. Okay, and lastly over here we have the microtropia. So you'll recall this is a small angle strabismus that's generally about 5 degrees or less, and we can subclassify these patients as having a microtropia with identity or a microtropia without identity. It's also worth noting that with a microtropia patient, they're not always primary deviations. They can occur post-operatively. As an example, you might have a patient with an infantile esotropia who has a 50 diopter esotropia. They will have an operation and the patient will remain with a residual esotropia, but they develop a microtropia. We'll talk more about this later, but it is worth noting that the microtropia can occur post-operatively and is not always primary in nature. Okay, that brings us to the conclusion of this video. Thank you for watching.